More commonly, we'll find that athletes experience lateral epicondylitis or tennis elbow, even though someone with lateral epicondylitis may not be involved in tennis. Lateral epicondylitis is seen most often in racket sports or throwers, but it can be seen in golfers. But usually with a golfer, it's on the non-dominant extremity. So let's take a look at it for a minute. With a thrower, think about the acceleration and deceleration phase. As the arm is progressing through the acceleration phase and it's coming down into the deceleration phase, you have to slow down the motion of elbow extension. So as we do that, a lot of times, if the biceps is beginning to become overloaded, a lot of times we'll use our wrist extensors to slow that motion down. Thereby, you're putting a lot of overload onto the wrist extensors at the elbow, resulting in epicondylitis. In addition, you have people who play racket sports like tennis. A lot of times use poor technique or poor equipment selection, and this in turn can result in epicondylitis. Most often when you find it in poor technique with tennis, you'll find that it's on the tennis backhand, and it's usually from a lack of proper mechanics, where instead of leading with the racket, a lot of times they'll lead with their arm and the racket will in turn come behind. Also, you can find that with tennis players, it can be due to poor string selection on the racket, poor racket weight, or even poor racket handle size. All these can come into consideration when you're looking at a tennis athlete with epicondylitis. Tennis elbow is actually a degenerative tendinosis at the origin of the extensor carpi radialis brevis, but it also involves the extensor digitorum communis. Usually it causes tenderness over or just anterior and distal to the lateral epicondyle. The point of maximum tenderness is usually within a 1 to 2 centimeter area of the lateral epicondyle. If it extends beyond this zone of tenderness, of maximum tenderness, then what you need to consider is where the area of tenderness is being localized to. Is it the radial head? Is it the capitellum? Because these could be indicative of a fracture of these areas, which can often be overlooked on X-ray. Looking at slide 297, here's an example of some of the provocative tests used for diagnosing lateral epicondylitis. One of the first ones that I like to use is called the Mills test, of course, which the elbow is extended and the wrist is flexed with the fingers flexed, and that way you put maximum tension onto the lateral epicondyle area. Usually by doing this before you even get into full flexion position, athletes will complain of pain in that area. So just like using the splint, we'd want to use a carpal lift in there. So if we look at slide 416, we can see that again we're using about a 1/8 inch, and you can use up to a 1/4 inch piece of foam padding or plastizote, just depends. If you use a plastizote material, just remember it's a little bit more firm, so you may want to use a thinner piece of material. And so in this sense, we've cut just a large enough piece to apply our lift to the carpal area. And on slide 417, we can see that during the taping technique, we've started on the hypothenar eminence using our leukotape and hypofix. And as we come around the ulnar side of the hand and the wrist, we're actually providing a dorsal lift to that ulnar side of the wrist. Thereby, we're giving that nice lift to the carpal area supporting the LT ligament. Now, if we look at slide 418, here's a nice picture of the instability taping that's completed. And as you can see by the arrow, it demonstrates the position of pull of the tape as it was applied to the wrist. Now, a good way to check is when you do apply the taping, before you apply the taping, what you might want to do is provide an external support to the area with your hand or the padding, have the patient grip, and see if they notice any change in their pain or symptoms at the wrist. If they do notice even the slightest bit of change to the wrist, then usually the taping technique will be effective, and at least it will be effective enough for them to continue to play or train, which is exactly what the physician wants, the coach wants, and the athlete wants. So as you can see on slide 418, this is a finished product of an LT taping technique. Now, in the instance, just like a scapholunate injury, a lot of times conservative measures fail, but the athlete will continue to play. So in this circumstance, of course, once the season's over or once their pain is reached to a certain point, they'll undergo an operative procedure to stabilize this area. So what we're going to look at as far as protocols is we're just going to go over a brief protocol for a lunotracheal repair with pinning. not Kirshner wires, but just percutaneous pinning. So be sure that if you do see a patient post-operative, you discuss with your physician what type of technique was used, and that way it will help you better to determine which protocol is best suited for this individual.